Alright, hi guys. So let's start the recall of FMG, and right now we are going to discuss June 2022. Now this recall that we are going to discuss is one of the most authentic recall, and I would say that we have put a lot of time and effort from collecting the data from the students usually, and it has taken a lot of time, and definitely you guys are going to enjoy this FMG June 2022 recall. So let us see the very first question that was asked. 29-year-old female with a history of hypercoagulable disorder visiting the OPD for anticoagulation. Which of the following drugs should be avoided in the first trimester of the pregnancy? Again, there is another case of pregnancy. So in the first trimester, what should be avoided? Again, warfarin. In the first trimester, we should avoid warfarin. Unfractionated heparin, low molecular weight heparin, they are the preferred, but warfarin is avoided because warfarin is associated with a condition known as your fetal warfarin syndrome. FWS is fetal warfarin syndrome, also given the name as a Contradi syndrome. Contradi syndrome. In the fetal warfarin syndrome or Contradi syndrome, usually there will be skeletal and facial defect. Skeletal and facial defect. There can also be nasal septal defect. Skeletal cartilaginous defects are also there. Cartilaginous defect can also be seen. Because of the cartilaginous defect, there can be flat nose as well. Cartilaginous defect can also be seen. So warfarin in the first trimester is not used. So always remember, if you are going to use anticoagulation during pregnancy, if you are going to use anticoagulation in pregnancy, then usually in the first trimester, from 1 to 13th week, we try to use low molecular weight heparin or unfractionated heparin. From 1 to beginning of the 13th week, that means end of the 12th week, beginning of 13th week. From 13 to 35th week, we can use warfarin because again we will be needing stronger anticoagulant. Warfarin is much stronger anticoagulant compared to heparin. Then in the 36th week, we are going to switch again to low molecular weight heparin or unfractionated heparin, either of them. I hope it is making sense to all of you guys. Alright, next. Which of the following drug is used as a agent of choice or drug of choice in Legionnaires disease? Very commonly asked question. And remember, in Legionnaires disease, in fact, any other atypical infection, Legionnaires disease, Legionella, atypical infection of the lungs that is caused by, let's say, mycoplasma, chlamydia, or atypical infection like Legionnaires disease caused by Legionella. For all of them, the drug of choice, it is going to be azithromycin. Macrolide, azithromycin is the drug of choice. Okay? Not the erythromycin. Erythromycin has again pharmacokinetic property like shorter T half-life, lots of drug interaction because of its enzyme inhibiting property. Vancomycin that we have, it's not preferred in Legionnaires disease. It's mainly considered the drug of choice in a patient with MRSA, methicillin resistant Staph aureus. It is the drug of choice also for Staph catheter associated Staph epidermidis infection. Catheter associated Staph epidermidis. Okay. It is also a highly preferred drug in pseudomembranous colitis. Earlier it was the drug of choice as well. In the oral dose mein vancomycin we were using, but again they are the among first line only. Currently the drug of choice for pseudomembranous colitis is fidaxomicin, one of the macrolide. Okay. Tigecycline, it is one of the congener of minocycline only. It's from the tetracycline family. Minocycline is from the tetracycline. One of the congener of the minocycline is tigecycline, that is having much better pharmacokinetic property, and it is also safe in renal failure. Which one? Tigecycline. And it can also be utilized in VRSA. If it can be utilized in VRSA, it can also be utilized in the MRSA as well. VRSA, MRSA, for all of them you can use them. Alright. So azithromycin is the correct answer for this question. A patient suffering from breast cancer is on chemotherapy, taking multiple anti-cancer drugs. As the cancer is not responding to the low dose of therapy, there needs to be increase in the dose of the chemotherapy. Which of the following agent require monitoring of the bladder function? Now, very typical question, and as I have told you many times in the classes, that your examination has become, I mean, your pharma has become clinical pharmacology, and now even the simplest of the question can be given in a form of case. So most of the question, if you see, they are going to talk about a disease or a case scenario. Wherever they are asking about a disease. Here, if they wanted, they would have just asked which of the following drug causes toxicity to the bladder, or any other drug that is causing, let's say, hemorrhagic cystitis. But here they are giving you a case. A patient is being treated on blah blah blah, and now he is having non-responsive cancer. You are going to increase the dose. Which drug will be requiring monitoring bladder function? So as simple as that. The basic concept remains the same. It's just that the pattern of asking has been changed. The correct answer is going to be ifosfamide. Please do remember drugs like your cyclophosphamide and ifosfamide. Out of them, ifosfamide is more notorious as compared to cyclophosphamide. These agents, ifosfamide and cyclophosphamide, these are actually metabolized, and one of the metabolite is known as your acrolein. Acrolein is one of the metabolite of cyclophosphamide and ifosfamide. This acrolein actually is toxic to the bladder, and because it is toxic to the bladder, it can lead to problem like your hemorrhagic cystitis, hematuria. Hemorrhagic cystitis, hematuria can also lead to bladder fibrosis. So with the drug like cyclophosphamide, ifosfamide, you always will be needing monitoring of the bladder function. And if you want to avoid this kind of toxicity like hemorrhagic cystitis, hematuria, bladder fibrosis, so as a prophylactic step, you will be adding IV mesna. You try to run an infusion of IV mesna prior to starting this cyclo or the ifosfamide. Okay. There is one more metabolite of this drug, just an add-on information, because they have already asked about this one a couple of times. There is one more metabolite, and this metabolite of cyclophosphamide, it is given the name as a chloroacetaldehyde. It is given the name as a chloroacetaldehyde. It's another toxic metabolite, and this chloroacetaldehyde, it is associated with a side effect known as your peripheral neuropathy. It can cause peripheral neuropathy. All right. So monitoring of bladder function again with the ifosfamide. Then we are having, let's say, methotrexate. They will be mainly associated with bone marrow suppression. They will be associated with your megaloblastic anemia. To reduce the toxicity of methotrexate, we always try to add a folinic acid, also given the name as a leucovorin. Then we have one more, cisplatin. It is highly nephrotoxic drug. To reduce the toxicity of nephrotoxic effect of cisplatin, we are going to add amifostine. Apart from that, remember, cisplatin is also one of the drugs that is having ototoxic property, and it is the most emetogenic anti-cancer drug. It is the most emetogenic, so maximum risk of nausea and vomiting. NNV, nausea and vomiting, most emetogenic anti-cancer drug. Gemcitabine will have the usual side effect, and in addition to that, remember, gemcitabine, it is also associated with hemolytic uremic syndrome, in addition to the other side effect like bone marrow suppression, alopecia, aphthous ulcer, right? In addition to that, they will have an additional, that is hemolytic uremic syndrome. Another question about gemcitabine that is very, very expected, that gemcitabine is considered as a drug of choice in pancreatic cancer. Drug of choice in pancreatic cancer, it is none other than your gemcitabine. Correct answer for this question is none other than ifosfamide. Moving forward to the next one. A young male patient who has a family history of bipolar disorder in his father, he now comes to OPD with the symptoms of mania. His genetic test shows positivity for recessive inheritance of genes involved in the mania. Which of the following mood stabilizer can be used? So simply they would have asked which of the following drug that is preferred in mania or used in mania. The answer is none other than lithium. Lithium is the drug of choice for mania. It is also utilized for the drug of choice for prophylaxis of mania. The answer for both the scenario, it is going to be lithium. But if the examiner is going to tell you that lithium alone is effective in acute attack of mania, please remember, for the acute mania, we can give lithium, but we need to add sedatives. So sedatives currently that is preferred is your atypical antipsychotics, or or benzodiazepines, atypical antipsychotics or benzodiazepine, and in addition to that you will be adding lithium. Please do remember that complete onset of action of lithium will take around 2 to 3 weeks. And in acute attack, you cannot just give lithium and you can rely that okay, the acute attack will be controlled. No, it will take around 2 to 3 weeks. Once the symptom is controlled with the atypical antipsychotics or the benzodiazepine, then slowly after 2 weeks you can withdraw those drugs and you can continue only on the lithium. Okay, so this is simply a case of mania or bipolar disorder, manic phase of bipolar disorder. The answer to this question is lithium. So preferred is lithium. But can we also have valproate? Can we also give valproate? Yes. In the manic phase of bipolar disorder, we can use valproate. In fact, valproate is the drug of choice for rapid cycler in a bipolar disorder. Rapid cycler, anyone who is having more than or equal to 4 cycle per year, उसको बोलते हैं rapid cycler. So bipolar disorder में again it's a drug of choice. ठीक है? But again in the manic phase of bipolar disorder or simply in the mania, the drug of choice is going to be none other than your lithium. All right. Carbamazepine can also be used in bipolar disorder in the manic phase of bipolar disorder. And olanzapine is atypical antipsychotics. A patient of myocardial infarction taking antiplatelet drug, aspirin, like 325 milligram aspirin. So aspirin is an antiplatelet drug, and this antiplatelet effect mainly is achieved due to the cyclooxygenase 1 inhibition. Okay. Which other drug can be added to the above therapy? Okay, so they are asking which drug will be added with aspirin. So with the aspirin, we always add aspirin is one of the COX-1 inhibitor, and in addition to that, we also add P2Y12 inhibitor. This P2Y12 inhibitor are drugs like your clopidogrel, prasugrel, है ना? Clopidogrel, prasugrel, and together we call them dual antiplatelet therapy, DAPT, dual antiplatelet therapy. In a patient with acute coronary syndrome, in a patient with myocardial infarction, this dual antiplatelet therapy studies have shown it is having 20% better outcome as compared to antiplatelet drug aspirin alone. So when we say dual antiplatelet therapy, we are going to talk about that drugs like COX-1 inhibitor like aspirin and P2Y12 inhibitor like clopidogrel. So usko bolte hain dual antiplatelet therapy. So here what will be added? Clopidogrel. Dipyridamole is an antiplatelet drug. It's a phosphodiesterase 3 inhibitor. Heparin is one of the anticoagulant. Warfarin is also one of the anticoagulant. Heparin is injectable, warfarin is oral. But here they are asking about antiplatelet activity. So warfarin, heparin are not antiplatelet, they are anticoagulant. Okay. Mechanism of action of aspirin in patients suffering from thrombosis. So see, this question itself I told you, COX-1 inhibitor is going to be aspirin. So mechanism of action of aspirin. So here the answer to this question is going to be inhibition of cyclooxygenase 1. P2Y12 inhibitor, I told you drugs like your clopidogrel, prasugrel, clopidogrel, prasugrel, ticlopidine. So in fact, examiner oftentimes simply asks also what is the mechanism of action of prasugrel or clopidogrel. Okay, so these are the irreversible P2Y12 inhibitor. Irreversible P2Y12 inhibitor. There is something called reversible P2Y12 inhibitor as well, and these are your cangrelor and ticagrelor. Cangrelor and ticagrelor. These are the reversible P2Y12 inhibitor. Okay. Fibrinolytics by converting plasminogen to plasmin. See, these are known as your tissue plasminogen activator. Tissue plasminogen activator drugs like your streptokinase, urokinase, है ना? Streptokinase, urokinase, LT-plase, NEET-plase, tenecteplase. These are the fibrinolytics. इनको बोलते हैं fibrinolytic. They cause conversion of plasminogen to plasmin, and this plasmin will be causing fibrinolysis. Inhibiting conversion of vitamin K1 dependent. The vitamin K dependent, this will be mainly your warfarin, not your aspirin. Okay. So I think other options have been also clarified here, that COX-1 will be producing your antiplatelet activity. P2Y12 inhibitors are drugs like clopidogrel, prasugrel, and fibrinolytics are streptokinase, and इनको बोलते हैं tissue plasminogen activator, है ना? Streptokinase, urokinase, and NEET-plase, LT-plase, tenecteplase, all those. Okay. Which are the following best drug for Raynaud's? For Raynaud's, the best drug, the most preferred drug that we are having is none other than your calcium channel blocker, specifically drugs like your amlodipine, nifedipine, We have other drugs as well. like you can use topical nitrates, nitrate topical, not nitroprusside. Nitroprusside is systemic drug. Beta blocker is not utilized. However, you can use alpha blocker as well. But if you compare calcium channel blocker and alpha blocker like prazosin, alpha blocker is having less effectivity as compared to calcium channel blocker. So calcium channel blocker are more preferred in Raynaud's phenomena. है ना? So we have drugs like nifedipine, amlodipine, and also they are taking diltiazem. है ना? They appear to provide symptomatic relief in Raynaud's. Some studies indicated that prazosin can decrease the incidence of digital vasospasm in patients with Raynaud's. However, its relative efficacy as compared to calcium blocker is not known. है ना? So this is a direct reference of this one is Goodman-Gilman 14th edition. All right. So the preferred one is going to be your calcium channel blocker. Which of the following is the most important and significant side effect of tamoxifen? See, tamoxifen, it is one of the selective estrogen receptor modulator. Estrogen receptor modulator. That means at some area they are agonist, at some area they are antagonist. So usually they are a drug of choice for ER positive and PR positive breast cancer. Drugs like your tamoxifen, raloxifene. Right? So they are going to antagonize this, right? But they are also having agonistic action. They are having agonistic action at areas like your endometrium. They are having endometrium. Because of that, they can lead to endometrial hyperplasia. Endometrial hyperplasia and can increase the risk of endometrial cancer. They can lead to endometrial cancer. But they are also having agonistic action at other area like bone. Because they are having agonistic action at bone, they are going to increase the blastic activity and they are going to utilize the treatment of osteoporosis. Right? So they are having agonistic action in many area, antagonistic action in some areas. Right? So again, endometrium and agonistic action can be leading to hyperplasia. So which of the following is the most important? So because of this reason only, we are not preferring this tamoxifen in in a postmenopausal women because of the increasing risk of hyperplasia. So alternative to this one, alternative to tamoxifen that we have is known as your raloxifene. Raloxifene, it do not cause endometrial hyperplasia because it is not having agonistic action. In fact, it is having antagonistic activity. It do not cause endometrial hyperplasia. So that is one of the second generation selective estrogen receptor modulator. So raloxifene is a relief actually. All right. So this is the same detail taken from the textbook. Whatever information is there, I have told you already, same detail. So tamoxifen is a SERM, I have told you already, widely used in ER/PR positive breast cancer, agonistic action over bone, therefore used in osteoporosis. They also have agonistic action at liver, uterine, endometrium. So the important point is agonistic action at uterine endometrium that is causing endometrial hyperplasia. Okay. It's utilized also in the treatment of osteoporosis because of its agonistic action at the bone. Because of its agonistic action in the liver, it can increase the lipid metabolism. Hence, they can also decrease the LDL level. So somewhere it is good as well. They are going to decrease the LDL level. So this is about your tamoxifen. Tamoxifen, always one point, tamoxifen can increase the risk of endometrial carcinoma. Next, a patient who has just recovered from COVID-19. So COVID-19 we have just seen. COVID wave ke baad se we had very massive surge of mucormycosis, and they always present with the black discoloration in the nose and posterior part of buccal cavity. He also gives the history of using high dose of steroid. So all of them, they will be pointing towards mucormycosis. Post-COVID, black fungus ke naam se they were famous, mucormycosis, and the drug of choice for that condition is going to be your amphotericin B, an antifungal drug that is going to act at the fungal cell membrane. So amphotericin B, it is considered as a drug of choice in this scenario, not any other drug. In fact, drugs like fluconazole, itraconazole, they are not very effective in mucor, and later on posaconazole was used. But if the examiner is asking most suitable or the most preferred, then amphotericin B is the drug of choice. For this one, we have quickly revised this once again. Thank you very much to all of you. I'll see you in the next class.